My name is Dominic Allain. I'm the Global Health Director here in our Global Health Program. It gives me great pleasure to introduce our speakers today. We have Dr. Stella Kioyagala. She's an assistant lecturer in the Department of Pediatrics and Child Health at Mbarara University. So it's the university, or Mbarara University of Science and Technology, where several of us have worked and volunteered in the past. She is a pediatrician, the head of the NICU at the Mbarara Regional Referral Hospital. She was the contact clinician for the KMC project, which we'll hear about, and she's a member of the Ugandan National Newborn Steering Committee. So I see Stella has joined us. Thanks for joining, Stella. Dr. Susan Niermeyer is a professor emerita of pediatrics in neonatology at the University of Colorado School of Medicine and the Colorado School of Public Health. She helped develop Helping Babies Survive educational materials with their incorporation into the WHO Essential Newborn Care and extension into Quality Improvement Integrated Kangaroo Mother Care. She's a consultant to USAID, preparing an operational guide for a scale-up of small and sick newborn care, which we'll hear about more. So hi, Susan. Thanks for taking the time. Dr. Khalid Aziz is a professor emeritus of pediatrics here in the Faculty of Medicine and Dentistry, and he's the medical director, quality improvement in the Office of Lifelong Learning at the U of A here in Edmonton. He's been a staff neonatologist in the Edmonton Neonatal Program and the Stollery Children's Hospital since 2007. He is editor of the EPIC Quality Improvement Workshop for Canadian NICUs, and he's a member of the Canadian Neonatal Foundation Board, which is a Canadian registered charity. And finally, Dr. Doug McMillan, who's a neonatologist and professor emeritus at Dalhousie University and the University of Calgary. He also helped develop Helping Babies Breathe and Helping Babies Survive learning programs and quality improvement integrated kangaroo mother care to assist healthcare workers in helping mothers and other family members care for their small babies. And Dr. McMillan will be joining, I believe, from India today. So, Doug, I'm not sure what time it is there, but thanks for taking the time, and he'll be part of our panel after the talk. So again, looking forward to a great presentation. We'll have time at the end for discussion and questions. And Dr. Aziz, I'll let you take the mic.
Thanks, Dominic, and thank you very much for the kind introductions. Just share my screen. So yes, I'm sort of a bookend here. Doug and I are sort of bookends to Susan and Stella, because a comprehensive program requires a lot of chapters in the book, both in terms of education and clinical science, but also in terms of implementation. So I have no significant conflict of interest to declare. I am the editor for the EPIQ education program, which is a quality improvement program for healthcare workers. I'm also on the board of the Canadian Neonatal Foundation that owns that program, and I work at the University of Alberta currently in the Office of Lifelong Learning teaching it. The QuickMIC program, which is a related program, is KMC integrated with quality improvement. And this program is available for free to low and low middle income countries in a low technology presentation format. So it's accessible if you are in an IP address in one of those countries. I'm going to just spend a few minutes setting the stage for Susan and Stella. I think most of you know this, that millions of children died in the first month after birth in each of the last few years. And it's approximately, in 2021, it was approximately 6,400 neonatal deaths every day. And many of these are preventable. And in fact, programs exist which are evidence-based, which can be used to prevent the majority of these deaths, because we see in well-resourced countries that the neonatal mortality is a tiny fraction of what it is in countries which are struggling to provide resources for children. The WHO and over many years has promoted something called Kangaroo Mother Care, which you're going to hear a lot more about. And for those of you who don't know, it's a method of caring for preterm and low birth weight newborns by direct, continuous skin-to-skin contact in the kangaroo position with their mother or guardian. And evidence indicates that KMC reduces mortality among clinically stable newborns weighing less than 2,000 grams when initiated in a facility. And this is particularly true in low and middle income countries or areas which are poorly resourced. KMC is not just skin to skin care. WHO recommends that KMC should be a routine practice for all preterm and low birth weight infants. It should be for 8 to 24 hours a day. In other words, babies are much better off in close contact with an adult than they are in an incubator or under a warmer. It should occur as soon as possible after birth. It should include feeding with mother's own milk, and there should be family involvement in routine care and the support of trained healthcare workers. What we have realized over the last few decades is that many countries face challenges providing kangaroo mother care, and a systematic review of the bottlenecks in healthcare in numerous countries showed that they occur at many levels, and you can see on the left they occur at levels of leadership, governance, health financing, health workforce, community ownership and partnership. So at many levels in many jurisdictions, it's challenging to provide this basic care for newborns. When you look at where the barriers are, if you were to look at sub-Saharan Africa, which they did in a systematic review, the barriers and facilitators are quite extensive. Here are the facilitators. It's a low-cost intervention. The policies exist. There's local leadership support. There is often sufficient space and supplies. So when you look at the articles, there are good reasons why it can be done, but there are also reasons why it cannot be done or is not done, and there are many barriers. So actually, the problem is not the science, and you'll see later the problem is not the education programs. Susan will talk about excellent education programs. The problem is actually in implementation, in the quality improvement of newborns. I was very fortunate to work in Ethiopia from 2013, and we recognized at that time that only a small proportion of babies who were born in the hospitals that were surveyed in this survey actually received KMC. So WHO actually proposed a study in India and Ethiopia, a multi-site study, and I'm going to describe this because I was involved in it. There have been other very successful studies, and Stella is later going to show you how she has implemented a very similar program in Uganda. So the study, which was proposed by WHO, basically brought quality improvement methodology, what we call plan, do, study, act cycles, into the development of quality improvements. And so every 6 months, they would try interventions and then measure whether it happened and create a new model for the next 6 months, and so on. And the result of this study after a few years is that we were able to identify the key barriers and solutions. We were able to go from virtually zero kangaroo mother care to very high population-based coverage, not just institution-based. And the initiation rates reached 60 to 90%. There were 4 Ethiopian sites, 5 Indian sites. And at discharge, 68% of the children enrolled in Ethiopia received kangaroo mother care, and 55% in India. And this was continued into the community with trained healthcare workers. So in conclusion, it was possible using the clinical science, the education science, and implementation science together to introduce kangaroo mother care into these facilities. I'm going to take the battery out. It's off my page. I apologize. One thing to recognize, I'm just going to finish up now because Susan will be talking about it, is that in order for a program to be successful, we do need to address the medical science, the educational science, and the implementation science. This is called the Utstein formula for survival. And what we are hoping to do at Kangaroo Mother Care is to have Kangaroo Mother Care training with an education program and with quality improvement. And through that, methodology. And here I describe the education program for quality improvement, which is EPIQ, the KMC education program. And these combined together is really the basic elements of what we call QuickWIC, which Stella will talk about, which is quality improvement integrated kangaroo mother care. Very similar to the pilot studies in Ethiopia and India. The objectives of the QuickWIC program are to make sure that along each step along the way and each stage in the healthcare system, there's preparation, learning, family learning, and follow-up of babies after discharge. So in closing, I'm going to close now because Susan is going to present next. It's quite feasible to integrate clinical and QI implementation. This can be done with any education program. And in doing so, it allows you to scale up, it allows you to engage people, and it does actually allow you to measure and appreciate improvements for babies, families, caregivers, and facilities. So I'm going to stop there. I just want to appreciate the fact that these programs have dozens, if not hundreds of people to develop, and there's too many to name. And I'm going to hand it back to Dominique.
Thank you so much, Dominique. It's really great opportunity to be able to talk to you about not only QuickMIC, but also the Essential Newborn Care Course Second Edition. This is a newly developed educational program coming from WHO, anticipated to be out in the first quarter of next year. But I want to give you some previews of that and how it dovetails with quality improvement integrated kangaroo mother care. So the long title of this talk you see on the slide there, but the short title is ENCC and QuickMIC Go Together. So this is a graphic from the series that launched the Every Newborn Action Plan, or ENAP, in 2014. And this graphic really emphasizes the potential of interventions around the time of birth for saving lives. So that tall bar there, care during labor, around birth, and in the first week, that care really has the greatest potential to save newborn lives, but also the lives of fetuses that you see in blue and mothers that you see in the dark purple. Care of the small and sick newborn adds another substantial number of neonatal lives saved in the postnatal period. So Khaled has already mentioned these WHO recommendations, but these two documents especially have really placed a lot of emphasis on the care of the baby at birth globally. Survive and Thrive defines 3 levels of care. The first, essential newborn care for all, special newborn care for those who require more advanced respiratory support, such as CPAP, and then intensive care for those who need mechanical ventilation and surgical intervention. There are also recently published WHO recommendations for care of the preterm or low birth weight infant. And these are the recommendations that really put kangaroo mother care at the very center of care delivery for these infants. Let's look a little more in depth at these WHO recommendations around kangaroo mother care. These really present the really strong evidence base for KMC as a routine for all preterm or low birth weight infants. These recommendations came out in 2022, and they were really a change from that initial set of 2015 recommendations in that they emphasized that KMC should be started as soon as possible after birth, so immediate KMC. And that includes babies who require respiratory support and even other medical interventions, as well as relatively healthy small babies. Family involvement in care is not only recommended by these guidelines, but essential to carrying out KMC. And families need education, counseling, and discharge preparation, as well as peer support as they assume an important role in their care of their newborn. So you've seen the formula for survival already. And as Khaled said, this is a concept that we stole directly from emergency cardiovascular care. But I think it really pertains in this situation as well. We know the science around KMC. We know what interventions are effective. The challenge really comes in delivering that knowledge efficiently and effectively, and even more in putting that knowledge and those skills into practice as a routine. So these are the factors that we can address with good educational programs and change practice that comes with quality improvement. So I want to give you a little preview of the Essential Newborn Care course that will be coming out later this year, at the beginning of next year. It really is built on the previous WHO ENC, but it now incorporates the educational methodologies of helping babies breathe. And you'll probably recognize some of those action plans down there in the lower left corner, as well as the companion programs of essential care for every baby and small babies. Early essential newborn care, which you see in the top left corner there, also known as First Embrace, and the WHO framework for quality there in the middle. These two have really brought additional emphasis to experience of care. So to the communication, respectful care, emotional support, not just the provision of the medical aspects of care. So now the ENCC 2023 educational resources incorporate all these elements and offer options of both print materials, as we're used to, as well as online learning with either computer or with mobile phone. So let's look a little bit at some of the similarities and differences between HBB and the new ENC. So ENC 1 is basically the equivalent of the Helping Babies Breathe action plan, with a few key differences. So it focuses on immediate care at birth and basic resuscitation. But there's really increased emphasis on respectful maternal and newborn care. So welcoming the mother at the beginning of the action plan here at the top, and including respectful care as a cross-cutting theme there running along the side for really all of our actions in delivering care. Routine care on the ENC1 action plan now extends through the first hour after birth, with uninterrupted skin-to-skin care for at least that 1 hour, and initiation of breastfeeding included as a discrete action step at the end of the green zone. So ENC2 now focuses on assessment and continuing care throughout the facility stay after birth. And you can see it's sort of a combination of the action plans from Essential Care for Every Baby and Small Baby on the left. So this single action plan really focuses in the intermediate or yellow zone there in the center on provision of prolonged or continuous skin-to-skin contact, the basis for kangaroo mother care. It also spends a lot of time on methods to further improve thermal care, very important for small babies, breastfeeding and feeding of breast milk by alternative methods, and the regular reassessment of a baby's growth and condition that are necessary to update the care plan during a more prolonged stay in the health facility. So in short, ENC2 packs in a lot of the essential knowledge and skills to provide kangaroo mother care. So it's also important, I think, to acknowledge that ENC1 and 2 really preserve a lot of the tested learning methods of helping babies breathe. The explain, demonstrate, practice, discuss, but also incorporating video demonstrations, both with a simulator and segments from the Global Health Media Project videos that illustrate actual clinical scenarios and prompt participants to reflect on what they're seeing and how that compares to what's going on in their own health facility. There are group practice simulations and peer learning, all conducted in the health facility as the site for this education. And these simulations use self-reflection, feedback, and debriefing, those key tools for improving performance. The assessment process is really also used in a formative way to build knowledge, skills, and performance. And this is a very competency-based educational program. And then finally, ENCC also incorporates quality improvement activities after the workshop. There are simulation practice exercises and also clinical practice that really can directly lead participants to identify gaps in care in their own facility and then move to design improvement cycles based on those observed gaps. So the ENC2 action plan also can turn into a set of process and outcome indicators for quality improvement. And as we've said, a lot of the action steps on this action plan are really centered around issues relating directly to kangaroo mother care. So it's a great basis to build upon as you're doing quality improvement with KMC. So now let's take a look at QuickMIC. You've already seen this opening page of the flip chart for QuickMIC, but it really outlines the objectives, and this is the participant-facing page of the facilitator guide. So it emphasizes, as Colin said, preparation, but preparation not only of healthcare workers, but also of the facility and its administrators, and the mother and her family, and the broader community that's supporting this health facility and this family. Both healthcare professionals and family members are involved as learners in this program. And follow-up care is a real key component for quality improvement targets and achieving successful patient outcomes. So now let's look at the facilitator-facing side of the QuickMIC flip chart. And this is also very familiar to people who have used Helping Babies Breathe, any of the Helping Babies Survive materials, or the Essential Newborn Care flip charts as they become available. So you can see there are sections ask, demonstrate, indicate, invite further discussion. And there are also videos incorporated into the flip chart. Some of these are full-length videos on topics that really augment the short clips that are included in the Essential Newborn Care course. So group practice exercises are really central to this active learning, both in essential newborn care and here in QuickMIC. And this is there are two types of group practice. This is the one that really emphasizes communication and mother's learning. So the mother is actually, and I'll go back to this. The mother is actually involved in this exercise along with the healthcare worker. And it's really teaching the healthcare worker how to facilitate a mother's learning and acquiring the skills to care for her own baby in the facility and then translate those skills to care after discharge. And this is an example of the other type of group exercise in QuickMIC. This second type really focuses on application of quality improvement techniques. So here you see a fishbone, and we're going to work through a problem or a specific gap in care in providing kangaroo mother care using these QI targeted group practice exercises. So in summary, the principles in the development of QuickMIC really support interactive learning similar to ENCC. They focus on healthcare workers assisting the learning of mothers and family members. And they use QI tools to help overcome barriers and understand change. The program emphasizes accessibility of this learning to really facilitate its rapid dissemination globally and limits cost for education and KMC implementation to help sustainability. I want to leave you with links both to the Helping Mothers and Babies Survive site, where you can find interim versions of the Essential Newborn Care Course 2023. These are not the final update yet, but I think it will give you a good look at especially ENC 1 and 2. And then, as Khaled has already mentioned, the QuickMIC materials are available through the Canadian Neonatal Foundation and also on the IPA website. So in closing, I just want to remind us all that the goal of both Essential Newborn Care and QuickMIC is to create this continuous cycle of learning and improvement. So it begins with updating knowledge, then mastering skills, practicing in teams, gaining clinical experience, and finally improving care, because our ultimate goal is really a healthy baby, family, and providers. Thanks so much.
The success of our partnership with Rotary Club that helped to introduce a successful QI project on kangaroo mother care in southwestern Uganda. So kangaroo mother care is an intervention that consists of early skin-to-skin care, exclusive breastfeeding, close monitoring of the babies, and early hospital discharge. And the benefits of kangaroo mother care is well known and established to most of the health workers, like achieving good thermal stability, having infection prevention, having adequate weight gain, and that promotes earlier discharge. However, even with the knowledge of these benefits of kangaroo, its establishment and sustainability has been a challenge to most facilities. And at Mbara Hospital, we did not have any dedicated space for kangaroo by 2020, and kangaroo was not smoothly ongoing by then. And yet we've seen that at our facility, our biggest challenge and contribution to neonate admissions and mortality has been prematurity, with it contributing to more than a third of the newborn deaths in our facility. And so we thought that this would be an appropriate intervention in helping to reduce the mortality of newborns at our unit. So with the process, we set out with the aim of establishing sustainable kangaroo at the facility. And so with these thoughts and a proposal that was written, partnership was sought, and we managed to get recommendations from the local Rotary Club of Mbara, that guided by Dr. Kumba, who is the head of department here. And that had a discussion with Dr. Doug, who comes from Rotary Club of Stampede in Canada. And the two clubs agreed that this was a good project, and they submitted a proposal to Rotary Club International that approved and funded the project. With the funding, we were able to acquire equipment like oxygen concentrators, infusion pumps, and phototherapy machines, so that the small babies can be cared for in the initial days to stabilize enough to be able to do kangaroo. And we were able to acquire the wraps. These were made based on the Liado standard. They were made locally to support local revenue, but also to ensure that if we need them in the future, we'll have someone who can make them for us. And then we had training of both health workers and ongoing training for parents of preterm mothers. And then we were able to establish a 4-bed kangaroo cave, and also facilitation of food for mothers who are having preterm babies was put in place, because these mothers stay for long. For us, we have early involvement of mothers into the care of these babies, so they stay with the babies in the hospital for 2 to 3 months, and if they have quite small babies, and so they run out of funds for food. So this was an important aspect for us, to see that they stay in hospital and be able to get to care for their babies. And so all activities started in January 2021. And if you remember, at this time, we were still in the peak of COVID-19. So this is a picture showing the established kangaroo cave. It has 4 beds. And these were some of the mothers who were doing kangaroo in the room. And then this is a picture from one of the trainings. We did a total of 3 trainings, and this was one of the trainings. We were teaching the health workers about kangaroo, and then they were running scenarios, and they were doing it perfectly well. And in this picture, this is the ongoing utilization of the supplied equipment on the ward. This is our NICU in the first image here. And if you look below the blue light here near the window, but below the blue standing light, which is the phototherapy light, there is a small baby here. And this baby is under phototherapy, is receiving oxygen from this gray concentrator, and is also on an infusion pump. All this equipment was got from this project, and this was one of the baby maximizing its use. And we are happy because we have an on-site biomedical engineer who is able to service and maintain our equipment and ensure that we can continuously and safely use the equipment. And in this picture, this is one of our mothers who was receiving food from the kitchen. And this was a success for us, because it helps mothers to get enough breast milk to be able to do exclusive breastfeeding, because we do not do formula feeding for our preterms at our facility. So what are the results we got? One, we were able to train a total of 59 health workers who are trained in different aspects of newborn care, like essential newborn care, both package 1 and 2. And they were also trained in EPIQ for quality improvement projects. And also they were trained in quality improvement integrated KMC. And our participants, all the post-evaluations demonstrated good knowledge acquisition and skills. And 5 of them are now trainers in all these packages. And they are helping us to continue the local trainings without international support. And then we started on QI projects to support sustainability of kangaroo and better newborn care. And the 2 I can gladly talk about. One was initiation of breastfeeding within the first hour for mothers who have had cesarean sections. Before, only less than 5% of the mothers were able to start breastfeeding in the first hour. But we are glad to say that At the moment, even before completion of the project, we've reached 30% of the mothers to initiate breastfeeding within the first hour. And also the other one was correction of hypothermia at admission to prevent newborn deaths associated with hypothermia. And that has been a great success for us. So the other results realized was the True KMC, which is ongoing at the site. In 2021, we started out, we achieved only a 17% from less than 5%. We were at 17% by end of the first year of the mothers doing kangaroo. But initially this was due to limitation of space. We had only 4 beds. And also during COVID, the staff, we were not regular on the wards to support these mothers. And by the second year, by the time we finished the second year, we had more beds, as we shall see. We improved from 4 to 8 beds. And also we were more involved with the mothers, so we achieved a 50% rate of doing kangaroo for these prematures. And also, right now, our limitation to go further is still space. Because this week when I walked in the bed, in the ward for kangaroo, I found each bed having 3 mothers, so they were not having enough space to complete their kangaroo. And then the direct benefits of kangaroo were realized. We reduced mortality among mothers and among babies who had started kangaroo to only 3.4%. And so it's assured that when you start kangaroo, your chances of survival are nearly 100%. And then we have better thermal control. From our records, babies who did kangaroo had better maintenance of temperatures. And then faster weight gain, and which has resulted in reduced self-discharge because mothers see their children growing faster and they are willing to stand complete until the required weight. And then reduced infection rate and readmission into the NICU for complications of prematurity, and also reduced hospital stay was the overall outcome from 14 to 9 days. And then the other outcome we've seen is family-centered KMC. When we started out, we were dealing with only mothers, but as we realized that more family members were interested in helping these mothers. And in this picture, we can see a grandmother supporting the daughter to do kangaroo for one of the twins that she had. And this has helped sustainability even in the community. And this picture of this adolescent boy always reminds me of the courage that people and the interest that everyone has in doing kangaroo. And this adolescent boy, the mother delivered a very small preterm of less than 1 kilogram, but she got pregnancy complications, got severe preeclampsia, and was admitted in ICU for nearly 3 months. So this boy offered to do kangaroo for this little brother of his. And by the time the mother's discharged from kangaroo, this baby had gone from less than 1 kilo to 1.5 and was ready to go home. We've also seen active involvement of fathers in doing kangaroo. And to our surprise, they actually love doing kangaroo. And they are strong advocates and show great passion for kangaroo. And one of the fathers said, when my baby grows up, I will actually tell him that it was my warmth that helped to keep the baby alive. And we've seen continued parent education. This picture shows 2 mothers. This is not a health worker in black. This is a mother teaching a fellow mother on how to do kangaroo. And as we can see from the picture, she has perfectly positioned this baby into the kangaroo position. And she's going to demonstrate to the mother how to secure the baby in the chest. This has ensured sustainability of kangaroo in the unit. For mothers who are newly admitted to the cave, they are able to be taught by fellow parents to learn how to do kangaroo. And even before the health worker comes, you find that these mothers have already started doing kangaroo. And we've realized secondary benefits and results like to the unit, we had increased financing from Ministry of Health because it was based on results-based financing. When they came, they realized we had items, equipment, and sections that we've created that were not established by the ministry. And so we were rewarded with financing for things that we've put in extra effort to achieve despite not having the government funding. And then we've been able to extend our Kangaroo Care from 4 to 8 bed capacity facilitated by the hospital administration because they were seeing the direct benefits of this intervention. And we have now better motivated staff who are happier because they have the equipment and they can see better outcomes for our babies. And we have sustainability of kangaroo. Research has started because now we have a dedicated space. People are interested in doing research concerning kangaroo. And I'm glad to say that all kangaroo activities at our facility has continued beyond the funding period, which was 2022. And from these images, this year, on 17th November, we were celebrating the World Premature Day from our NICU and from our kangaroo area. As you see, this is our head of department in the middle, Dr. Kumba Kumba, cutting a cake with our mothers who were doing kangaroo. And behind here and on this side are the kangaroo caves for our mothers. And then on this picture, on the same day, I was in the kangaroo cave itself with our mothers who are doing kangaroo. And so it is ongoing and it will continue because we have the space. Lessons we've learned is that kangaroo is possible even with limited space. Parents and caretakers are willing to do kangaroo, and kangaroo has both direct and indirect benefits. So thank you so much for such a good partnership that we've had, and thank you for listening to me.
Great. Thank you so much, Dr. Stella, for your video presentation, giving us such a good overview of the many successes of the Kangaroo Care program in Mbarara. I think can really set the example for many other areas of the world, which we can discuss a little bit more in our discussion period. So thank you again. So just to close off, thanks again to all of our speakers and our panelists for taking the time to tell us about such an important program on the global stage and all of your efforts. We thank you on behalf of the newborns around the world and their families, the mothers. I think there's so much potential with this program. So thanks again, and thank you to the participants for taking time.
Thanks, Dominic.
Okay, have a great day, everyone.
Thanks. Bye-bye.
Thank
Bye.
you.
Thank you so much.